وان شاء الله صح فطوركم. معكم الدكتور محمود الكايخ، انا خريج طرابلس 87. وان شاء الله الليله هنتكلموا على الاكني. لما قال لي منير على يتكلم على الاكني رجعت بي الذاكره حوالي 25 و30 سنه فاتت لما كنت في طرابلس، وكيف كنا نعالجوا في الاكني. By the way, منير, do we have any non-Arabic speakers?
لا كلهم عرب دكتور، وهم يحبوا انك يعني تحكي عربي وانجليزي يعني.
اوكي
تمام.
فحوالي 30 سنه فاتت كنا نعالجه في الاكني كانه حب شباب، يعني حب بسيط. معظم المرضى نقول لهم هذا حب شباب وحيختفي منك و don't worry about it. We were very relaxed about the management of acne. But over the last few years, this concept has completely changed. Acne has been shown that is a very inflamed skin condition and chronic skin condition, and I'll show you tonight why acne is not just hab shabab, it's a very chronic and inflammatory skin condition. So tonight, what I'm going to do, just bear with me a second, please. Tonight, I'm going to talk about acne. I'm going to talk to you about what's acne, what are the causes of acne, what are the pathogenesis of acne, what are the clinical signs and different types of acne, because acne is not just the normal acne that we usually talk about, and we talk about also the psychological burdens of acne, which should be always considered when you deal with a patient with acne. And we'll talk about treatment of acne and what's new in acne. So acne is a chronic, and this is each word, what I'm going to say now, it means a lot. So chronic, which means it's not an acute condition that you can give treatment to your patient and you will cure it from it. You always explain to your patient when you see him, either in the clinic or even for the sake of your exam, or if you are a dermatologist or a general physician, tell your patient, him or her, that acne is a chronic condition. It needs months, maybe years to keep it under control. It's an inflammation. It's an inflammatory skin condition. It's not just the changes in the skin. There's a lot of inflammation underneath your skin even before the inflammation occurs, and it happens in the Pilosebaceous unit. And the Pilosebaceous unit is the unit of the skin where all the inflammation of acne happens. And I'll tell you what's Pilosebaceous unit, because if you don't know what it is, you're not going to understand what's acne. And this is a drawing on the skin of the Pilosebaceous unit. So normally we have 3 layers of skin. We have the epidermis, which is the top layer here of the skin. Can you see my arrows, every one of you? My mouse movement.
نعم.
Yeah. So you see the top layer of the skin, which is the epidermis, and you see the second layer of the skin, which is the dermis, and then you see the last layer of the skin, which is the fatty layer of the skin, and we call it subcutaneous layer. Now, in the second layer of the skin, we have a lot of structures, very important structures for the skin. And here is the Pilosebaceous unit. And here is where every pathologist, every changes on the skin happens. So the Pilosebaceous unit is a structure consists of the hair follicle, hair shaft, which goes up from the hair follicle up to the epidermis, up to the skin outside. Then we have the sebaceous glands, which is here. And the sebaceous gland has got a sebaceous duct where the sebum goes out through the hair duct and goes out to the skin. And we have a very important muscle that control the contraction of the hair and the other structure, which is the erector pili muscle. So all these structures are the Pilosebaceous unit. And here, where the inflammation of acne and even rosacea happens. And then we have the other structures with the veins, nerves, arteries, lymphatics of the skin. And here, this is a cut section of the skin. And you can see here, this is most probably face or skin or the scalp, because there's a lot of hairs here. And this is the hair follicle. This is the hair shaft. This is the opening of the hair out on the skin. This is the sebaceous glands here. And this is the erector pili muscle. And the same here, this is maybe more clearer here. That's the hair follicle here on the fatty layer of the skin. This is the hair shaft. This is the sebaceous glands here, and this is the rectal pili muscle. And this is the rectal pili muscle here. So this is, and if you take a biopsy in a patient of acne, you will find a lot of inflammatory changes around the structures here. The epidemiology of acne, as you know, acne is a very, very common skin condition. It affects about 80% of the teenagers. And in America, there's at least 50 million are affected by USA, in USA affected by acne. So at least 10 times of the Libyan populations. It's usually more common in males in the early teen ages. So it usually appears in males in between 10 to 17 years old, and this most probably because of the androgens. And in females, a little bit later, so it's around 14 to 19. So in the early ages, more common in males, in later teen ages, more common in females.
اسف دكتور مع المقاطعه في الشات يقولوا السرعه شوي بس ممكن
نقص السرعه يعني. اوكي ان شاء الله. تسمعوا فيا كويس سوا؟
نعم الصوت واضح.
بنعاود من الاول، تبي نعاودكم من الاول؟ تبي نعاود من الاول ولا نستمر على ننقص السرعه شويه؟
لا قالوا تمام في الشات.
اوكي. دقيقة بس. شوفوا في الباوربوينت الآن.
نعم دكتور.
Okay, so قلنا 85% of them teenagers are affected by acne. حوالي 50 مليون teenager يعني شاب وشابة في أمريكا are affected by the acne. وأنا قلت لكم هذا حوالي 10 times of the Libyan populations in America are affected by acne. The males عادة appears in between 10 to 17. يعني البويز في الأكني تطلع عندهم الأعراض of acne more earlier than girls. So in boys you find them between 10 and 17. في الجيرلز around 14 to 19. علاش يقول لك لما لو تقرب حول الأكني you'll find that it's more common in boys or in males in early age group, commoner in females in later age group. Acne does not disappear when you reach 20. You can have acne and after 20 and up to 60% of patients. You can see patients with acne even after 20. You can see, I see patients in acne sometimes in my clinic in 40s and 50s. So about 45% of patients, you can see them later than 30. It can affect any ethnic group. In Asians, about 10%, and Afro-Americans, and about 25% of them are affected by acne, and Caucasians or white peoples, usually around 20 to 30%. Now, this is a very important slide that you should look at it when we finish and to understand the causes and pathogenesis of acne. So we will start from the top left corner here. So when the child reaches teenagers group, boy or girl, there's a lot of excessive secretion of androgens, which is like testosterone. Now the testosterone will work on the sebaceous gland or the pilosebaceous unit. I've told you about them. So which means that the pilosebaceous glands and the sebaceous glands will become enlarged. And this will lead to excessive secretion of sebum. And this we call it follicular hyperkeratosis, so more differentiation of more active sebaceous glands. So when the glands become more large and more active, will increase more sebum, the oily stuff, the دهنيات اللي نفرزوا فيها من الجلد، هذا هو sebum. So there will be more increase of sebum. The sebum sometimes will stagnate, will stay on the duct. It doesn't go out in the skin, and will block the opening of the sebaceous glands on the skin and stay underneath the skin. When you have a lot of sebum underneath the skin with blockage of the opening of the hair follicles, the bacteria, which you can see here, the bacteria is very happy because they'll find a very good media to grow in and multiply. And most of the bacteria that cause the problem, usually we call it in normal flora. Usually we have it in our normal skin. And the most common bacteria that you need to know, maybe one or two of them for the sake of your exam, is the Cutibacterium acne. In the past, we used to name it Propriobacterium acne, but now it's started to be called or named Cutibacterium acne. The second bacteria, which is again normal flora normally, is Staph epidermis. And then the other bacteria, Corynebacterium granulosum. So these, the main three bacteria that when there's a lot of sebum here in the black square or black box, they will multiply and they will cause the inflammation and the infection of the sebaceous glands. And this then will lead to the signs of acne that will start to show on our faces. Comedones, papules, pustules, cysts, and eventually scars. And you should, when you treat your patient of acne, you should try to treat him aggressively and early stages here to prevent him going or hair going to this stage of scars. Because once the patient have scars, that's it. You're gonna run in a lot of problems. So just to repeat again, excessive secretion of testosterone in boys or girls will lead to enlargement of the sebaceous gland that I have shown you on the slide, will lead to what we call follicular hyperkeratosis. This will lead to increased production of sebum. The production of sebum will stay underneath the skin and block the opening glands and ducts. The bacteria that normally friendly in our skin, when they found a media to grow and multiply, which is the sebum, and these are the names of the bacteria, will cause infection of the sebaceous gland and inflammation. And then you will have the clinical signs. is the speed كويس يا منير ولا ننقص شويه سرعه السبيد؟ منير 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 تسمع فيها؟ الو منير منير شوفوا فيها الآن. اوكي الرسمه هذه بتوري لكم الانفلامation والprocess of the causing of the acne that I've just spoken about. So this is here the normal skin. So this is the top layer, which is the epidermis, and this is the second layer of the skin of the dermis, and this is the pilosebaceous unit. In early stages, you will see some inflammation early before even you have the comedones and the papules and the pustules. So there will be, as soon as the androgen will start secreting, before the inflammation appears, there will be monocytes, inflammation, and then these stages of the development of acne will appear. So there will be the microcomedones, and microcomedones is a small, enlarged, closed lump underneath the skin here, where there is a lot of sebum. Then one of these inflammatory process will happen. So you can have either closed comedones, and the closed comedones is when there is a lot of collection of the sebum underneath the skin and doesn't go out. And this is, we call it white head. Then you have white open comedones when the collection is deep underneath the skin, but the opening of the skin here in the hair shaft is open. And this, we call it a blackhead, and then you have the inflammation when there's infection in the skin and the papules, pustules, and then eventually scar. Again, we'll show you here the process. So this is the normal hair unit here, Pilosebaceous unit, the hair shaft, the hair follicle, the sebaceous gland, and rectal pili. When there is a lot of inflammation and the androgen will start to secrete, the comedones will start underneath the skin, and most of the sebum sometimes will go out and leave an open head, which we call it a blackhead or open comedones. When the sebum stay underneath the skin, it doesn't go out and push the skin outside, is called closed comedones. And then when the inflammation keep going and you don't control this process here at the open comedones and closed comedone, you will have the more inflammatory acne, which is more of papules, pustules, cysts, and scar. And this is what we call a nodulocystic acne. What are the clinical signs? So we'll talk now about the clinical signs. So there are two types of clinical signs. There's primary lesions, which is mainly secondary to the acne, and there are secondary lesions. In the primary lesion, there are superficial lesions, which is you see them in the top layer of the skin, and there is deep lesion deep on the dermis of the skin. The most common sign that you always see on the acne is the comedones. So comedones, there are open comedones, and there is closed comedones. The open comedones, also we call them blackhead, like what I have showed you. See just blackhead, and you have the closed comedones, which is whiteheads. And then we have papules. And then we have papules, which is slightly large red spots, less than 1 centimeter. Then we have pustules, which are small lesions full of pus. These are the superficial lesions. Then we have deep lesions, which are nodules, which is more than 1 centimeter. And then we have pseudocysts, which are large, deep, fluctuating swelling with inflammation. Then we have secondary lesions, and the secondary lesion are not pathognomic of acne. And this is usually because if either the patient is excoriating or scratching the skin, and you'll see scratching the skin because of the patient, whether male or female, standing in front of the mirror, try to get rid of up of these lesions. You'll see small red multiple patches on the skin due to the healing process. And most important, which is very scarring sometimes to the patient, is post-inflammatory hyperpigmentation, where you see multiple black spots due to the discoloration of the skin. We call it post-inflammatory hyperpigmentation, and then scars. And then we'll show you now clinical pictures of blackhead. You see here in the nose, blackhead usually very small, multiple dark lesions. And this is tell you what we mean by blackhead. So this is the pilosebaceous unit here. This is the follicle. This is the sebaceous glands. And the sebum will enlargement of the hair follicle here, but there is no sebum. And then there is the opening on the top of the skin. And this is, we call it blackhead. So the blackhead is an open comedones. And they are usually multiple, usually are very pathognomic and very diagnostic of acne. And also, as I said, called open comedones. And that usually see them in the nose, cheek, and forehead. And this is a clinical picture of blackhead. This is very pathognomic. And if you have a short case of acne, the examiner would like to ask you, show me the blackheads and the whiteheads. So this is the blackheads, very multiple, small, black dots. زي سن المسمار تلقاها في الوجه عادة في الشيكس وفي النوز وفي الفورهيد وفي الشن. If you see carefully, you see scarring here. This is, we call it atrophic scar. So this patient have a very advanced acne. There is another scan with post-inflammatory hypopigmentation, white spots. Again, multiple scars here. So this is blackheads. Then we have another diagnostic features of acne, which is the whiteheads. And whiteheads is where the opening of the hair follicle and hair duct is closed. There is not open, and there is a large hair follicle underneath the skin, and you see multiple small whiteheads. So blackheads and whiteheads are very diagnostic of acne, particularly early acne, and have the same distribution like closed comedones. You see them again in the forehead, you see them in the cheeks and the chin, and you see them sometimes together. And this is a combination pictures of how you see whiteheads, multiple small white raised papules. Underneath these papules or spots here, there is a closed hair follicle, and this is a closed comedone. So whitehead is a closed comedones, blackhead is an open comedones, and this is the blackhead, and these are very pathognomic of acne. Then you move to the second sign of the superficial signs of acne, papules and pustules. I said papules are small, less than 1 centimeter, red raised spots on the skin. Can you see there? This is papule, this is papule, this is papule. And then you have the pustules, which is similar to papules, but they have pussy heads, so full of pus because of the infection. Now this one here, this scaling here or crusting, it's not part of the acne. This is secondary changes that I've told you about. This is because of the inflammation, because of the healing. Maybe the patient will try to squeeze them and remove them by hair or his hands. And then you'll see multiple red lesions here. All these here are due to the healing process of acne. So papules, pustules. There is no clear evidence. There is maybe whiteheads here in this area. So this is how acne appears. Again, this is another pictures show you the papules and maybe pustules and nodule. This is slightly large subcutaneous lesion. This is maybe white papule here, white comedone here, multiple papules here, and this is more obvious pustules, papules, scarring, even scarring, and white comedones here, and maybe black comedones or blackheads here, another white comedones here. So this is what you will see in patient with advanced acne or in your short case examination. Then you have the nodules or subcutaneous nodules and pseudocysts. So you can see quite large, very inflamed lesion, and if you feel it, sometimes you feel it very hot and full sometimes of pus. There's one here. There's maybe some comedone in this patient here, comedones here, bit of inflammation here, and again this is pseudocyst or cystic. This is called nodulocystic acne, and there's a bit of scarring and bit of papules here, comedones in this area, and another nodule here. Again, this is so this is multiple subcutaneous nodulocystic acne, and never ever allow your patient, if you are a dermatologist or a pediatrician, never ever allow your patient to get to this stage or this stage, because once, particularly in this poor guy here, this is very advanced acne, and this will need a lot of treatment and maybe even cosmetic treatment. And this is multiple pictures of acne to show you how acne can present in different stages, either primary stages or primary changes or secondary changes. These are the blackheads. You can see the blackheads all over. You see that the patient was trying to scratch this one, so he or she is doing this problem. You see the papules here, which is small red spots. Again, this is a very marked or advanced acne. Nodule here, multiple scars, very small scars here, like a very indentation. We call them ice picks scars. Again, this is nodules, multiple nodules, very marked blackheads here, very marked scarring here. You can see here very marked scarring here. And then multiple inflammatory nodules and papules on the skin. This is the post-inflammatory hyperpigmentation here. You see multiple brown patches or dark patches in the skin, particularly in the face and forehead. And this is due to the healing process of the inflammatory acne. And the skin will lay down melanin and cause this darkening of the skin. And here, these three pictures, never ever try to allow your patient to get to this stage. And if the patient gets to this very severe nodulocystic scarring acne, you will, it will be very difficult to treat it. And even if you control the inflamed acne, it will be very difficult to cure the scars in this lady here and these two men here. So this is how the different stages of acne appear between comedones, nodules, papules, pseudocysts, and scars. Now, severity of acne, I mean, there were a lot of classification how you assess the severity of acne, but recently the most widely accepted one is to classify it into mild, moderate, and severe acne. And you can see here, mild acne, they say always less than 30 lesions, moderate between 30 to 125, severe between more than 125. But for the sake of your exam, you are not going, if you have a short case in your exam of acne, you are not going to stay in front of the examiner and count how many comedones and how many papules are and nodules. You can just, if you, to save your time, say between mild to moderate acne, or moderate to severe acne, or at least look at the multiple nodules, roughly how many nodules or papules, and then you can say whether it's severe or moderate. But this is the severity of the acne, usually classified mild acne, moderate acne, and severe acne. And again, I repeat, in your treatment, if you are a pediatric dermatologist, try to always keep your acne at this stage. Don't try to allow your patient escape the net and get to severe acne. Now, types of acne. Now, acne, not just that spots that we normally see. There are different types of acne, and this is very important. Either multiple choice questions in your exam, or those who are doing the USMLE, or even sometimes in your oral, if you are doing well, your examiner might ask you what are the types of acne you know, or in your short case examination. So the first one is the acne vulgaris. Now, the word vulgaris means the most common. So when we hear acne vulgaris, this is the most common acne. When we hear the word psoriasis vulgaris, this means the most common type of psoriasis. So acne vulgaris is when you have papules, mainly comedones and papules. Then you have the second one, which is we call nodulocystic acne, when mainly the lesions are mainly nodules and cysts, and sometimes we call it acne conglobata. So remember this word. And this is, although it's very rare, but can be very, very drastic presentation, can be very bad presentation to acne, comes you if you are a junior doctor working dermatology or a senior doctor. And what happens, the patient come with acute onset, multiple interconnecting pustules and cysts. They have multiple lesions underneath connecting, like sinuses, connecting with each other. And this usually with multiple abscesses, and then with widespread inflammatory skin condition. This is what we call acne conglobata, or nodulocystic acne. Now, this type of acne sometimes can be associated with a very well-known syndrome. And again, this syndrome here can be a hot point for multiple choice questions, or even in your exam, in your oral exam. It's called follicular occlusion syndrome. And follicular occlusion syndrome is a triad, which have three signs: severe acne, pilonidal sinuses, and pilonidal sinuses, small sinus on the lower back in the lower part of the back toward the natal cleft around the back passages, on top of the back passages or above the back passages. And then the third one is the hidradenitis suppurativa. Now, hidradenitis suppurativa is used to be known, or still sometimes some people in some parts of the world, they call it acne inversus, which is عكس الأكني. acne inversus means إذا كان عندك الأكني أنت في الفيس ولا في الباك ولا في الشست، الأكني inversus عندك الأكني في الارمبتس في الإبط ولا في البرايفت area in males or females and around the back passages, and called hidradenitis suppurativa. So the follicular triad is this combination of severe acne, nodulocystic acne. You might ask about your patient if they have pilonidal sinus and hidradenitis suppurativa. And sometimes can be genetic, can be autosomal dominant. If you ask your patient about the family history, you will find that they have, it usually runs in their parents. Nodulocystic acne, again, is a very, very important sign in what we call an auto-inflammatory disease. It's not an autoimmune, completely different, an auto-inflammatory disease, and it's a very good presentation of about 2 or 3 syndromes. And again, this is very important multiple choice questions, especially for those who are doing Canadian board or American board or Australian board. So there is Papa, Papash, or Pash. Unfortunately, there is no Mama, just Papa here. And the Papa here, the first P and A start for pyogenic arthritis. So the patient will come to you with the recurrent infection of the joints, pyogenic arthritis. Then you have the second P here, pyoderma gangrenosum. And pyoderma gangrenosum is a chronic inflammatory, could be autoimmune, could be autoinflammatory ulcerations of different parts of the skin, particularly the legs. And then you have the second A, or the fourth letter here, which A is acne. So PA is pyogenic arthritis. Second P is pyoderma gangrenosum. And then you have the letter A. Also, you have Papash, which is similar, pyogenic arthritis, pyoderma gangrenosum, acne, and then you add the hidradenitis suppurativa here. Some people, they call it, or some countries call it suppurativa hidradenitis. So it's the same. So the same, pyogenic arthritis, pyoderma gangrenosum, acne, and suppurative hidradenitis or hidradenitis suppurativa. Sometimes you don't have the pyoderma gangrenosum. You have pyogenic arthritis, acne, and hidradenitis suppurativa. And as I said, this is very, very important autoinflammatory skin condition, and it can be very, very difficult to treat. Acne can appear in babies. Although when we say acne vulgaris, we always say acne appears in teenagers after بعد العشرة ولا بعد 12 في البويز وبعد ال 13 ولا 14 ولا 15 في الجيرلز. لكن unfortunately you can see it in babies up to 4 weeks, early as 4 or 6 weeks old, and it can continue up to 1 year, and even it can appear later in childhood, 8, 7, 9 years old. So always remember infantile acne. If you are a pediatrician or a dermatologist, or even for your the sake of your exam, you can see a baby or a child with infantile acne. And more common in boys, for a reason we don't know. It can be sometimes moderate or severe acne. It affects the same areas like acne in the teenagers. It can affect the chin, can affect the forehead, can affect the cheeks and nose, and have the same clinical pictures. Can have comedones, papules, nodules, and cysts, and even can lead to scars in early childhood, nearly as early as 8, 9. You can have a child with multiple scars due to acne. And whenever see in your clinic, whenever you see a baby comes to you with severe acne, you have to ask your juniors for their support, because this could be genetic, but it could be a source of or underlying problem, especially if the baby is having an excessive testosterone secretion, like adrenal hyperplasia or testosterone secreting adenoma or tumor. So always ask your senior colleagues to see and look at the baby. But generally speaking, usually self-limited and it doesn't cause problem, but always bear this in mind, excessive testosterone secretion. And I'll show you pictures of infantile acne. Now this one in the middle here, I'm just going to see your shares if there is any comments, because I couldn't hear you. This picture here called infantile cephalic pustulosis. Infantile cephalic, C-E-P-H-A-L-I-C pustulosis, or infantile acne. This one here. So this is infantile acne, and this is usually appear as 3 to 4 weeks old, and this can be treated easily with topical antifungal or with a bit of mild steroid cream. Now this is infantile acne. You can see the papules. This is infantile acne. You can see the papules and even the scars. This one here, again, infantile acne. You can see a child, older child with multiple acne, and this is scars. This is scars in a child with multiple, who has had acne when they were very young. Then we have another type of very severe acne called Acne Fulminans. So we have Acne vulgaris, we have nodulocystic acne or Acne conglobata, we have infantile acne, and then we have Acne Fulminans. And again, this is very rare and a very severe form, even more severe than the Acne conglobata, and can be associated with systemic symptoms. And sometimes when these patients come to the A&E or medical admission unit, يجوا للإسعاف بالمشكلة هدية ولا يمشوا للجراحة ولا يمشوا أحيانا because no one who knows about acne fulminans will think that the patient have got underlying medical condition. The causes of acne fulminans usually increase androgens, increase very sudden onset of increased testosterone. Usually autoimmune complex can be associated with other autoimmune diseases. Could be genetics, could be runs of family. Sometimes you induce the treatment. If you treat some of the patients with the Roaccutane or oral Isotretinoin, which is I'm going to talk about in a few minutes, you will end up with acne fulminans. Could be hypersensitivity. I've told you in the beginning that the bacteria, when there's a lot of sebum, the bacteria will get an access to the sebum and cause infection, and this can cause hypersensitivity reaction to this bacteria, particularly Cutibacterium acne. And again, this can be associated with another rare and important sometimes syndrome called SAPHO syndrome. So S for synovitis, which is inflammation of the lining of the joints. A is acne. P is pustulosis, so you pustules, acne with multiple lumps and bumps and pustules. H, hyperostosis, and O, osteitis, which is inflammation of the bones. So this is called SAPHO syndrome. You might need to remember this syndrome. So as I said, the patient will come with very sudden onset, very acute, doesn't come over months or weeks, usually within few days, 24 hour to 48 hour will come with a very, very sudden onset. And then the patient will have multiple inflamed, ulcerated, bleeding nodules on the face and trunk. He or she will come, particularly males, will come with fever, fluctuating fever, will have painful joints. That's why we said osteitis and SAPHO syndrome. 20% of the ankles, 20% are in the ankle, shoulders, and knees. And if you do an X-ray, you feel small osteolytic lesion with small holes on the X-ray in the bones. They will be very tired. They look miserable when you see them. Very tired, very malaise. They have lost their appetite. If you feel the tummy, their abdomen, you'll feel sometimes hepatosplenomegaly because of the inflammatory process. If you do their blood, you'll find anemia. Because of the inflammatory process, you'll find increased white blood cells, which is leukocytosis. You will have high inflammatory markers, SAR, CRP, and sometimes ferritin. Now, this is you need to start the treatment very quickly, and this is most probably the only one acne condition that you need systemic steroids. Usually in acne, you should not and never ever use steroids to treat acne, but in the acne fulminans, you need to use even a high dose of systemic steroids, aspirin, dapsone, which is a very strong anti-inflammatory drug, and even biologics, which is a very complicated treatment. And some people does not respond to all these treatments. You need, sometimes in some cases, patients need to use biologics. This is pictures of acne fulminans. You can see even without seeing the patient. This is just a picture. And you can see the patient looks very miserable. The face is very red, very inflamed, very erythrodermic, multiple ulcerated nodules, scabbing, crusting, covering the whole face, the whole forehead, the whole back. So this is a very acute emergency, and you need to treat it very urgently. Then scars. You can have a patient comes to you with just scars, have had acne later, early in life, did not, or early as an infant, and no one bothered. And when he or she reach 20, 23, 25, start socialize, then will start complaining of acne, and they will come. So, and that's why I always repeat this message, and I've said it at the beginning, always treat your acne, and very aggressively to prevent appearance of the scar. Patients with severe acne can have up to 7% more likely to develop scars. Patients who do not have treatment in early stages, they can have up to 3 times more likely to develop scars. So always put your goal, one of the goals of your treatment of acne is to prevent scarring of the patient. You don't need to know the names of the scars, but you should know that acne can lead the scars. No one, for the sake of your exam, will ask you what the names of the scar. It will be more than enough to know that there's a very thick scar called hypertrophic scar, or very thin scar called atrophic scars. And I'll show you the pictures of the scars. So this is how can acne scarring present, different presentation. Now this one here, you can see multiple, very hard, like stone, lumps raised above the skin. This is called hypertrophic scars or keloid scars. You can see raised, multiple red lesions. And you have atrophic scars. You have atrophic scars. And then you have different types of scars here, ice pick scars, carpox scars, and rolling scars. But as I said, you don't need to know these scars. Just know that there are scars, but you might know the hypertrophic or keloid scars. There is another type of acne called Acne Excorie. The word excorier is a French term for excoriation. And this is a term used to scratched or picked up scars. So what happens, the patient will stand in front of the mirror and usually start pick up any spot. Sometimes even if there is no any spot there, will start to pick up the skin and traumatize the skin, and will cause a lot of problem to themselves. And they will say to you, I am causing the problem to myself. I am inducing the problem. And this is usually have more psychological problems and more common in females. And the psychiatrists call it facial dysmorphic syndrome. So the lady will come to you and say, I have problem with my face. I don't like the shape of my face. I don't like how I look like. And there's a lot of spots I need to get rid of them. And and a matter of fact, she is causing the problem to herself. And this is why we call it facial dysmorphic syndrome. And you need to treat the acne aggressively. And also you might need to ask them opinion of the psychiatrist to treat the condition. This is how acne Excorie. You can see the face is almost clear, but these are induced by the patient herself. So you usually cause the picking up of the spots. Again, you can see multiple healing scars because the patient is causing the problem to herself. And this is quite obvious here, a big hole. This doesn't fit any clinical sign of acne. So this is picked up by the patient because of the psychological problem or the facial dysmorphic syndrome. You can see here the multiple healed scars on the face. So this is another important type of acne, Acne Excorie. Now, if I ask you now, can acne lead to psychological problems? I'm sure you will say yes. You can see the acne can cause a lot of problems. You can see the acne can cause a lot of psychological problems. And this is very important. You have to look at your patient as a whole. You are a physician, not just a dermatologist. When you qualify إن شاء الله وتتخرجوا وتبدوا تشتغلوا اللي بيشتغل منكم في dermatology, always look at the patient as a whole. Don't look at the skin only. Always know that acne can have physical scarring and psychological scarring. It can cause a lot of scarring to the patients. And I'll show you this lady here is making the hair falling down, not because of fashion. This is trying to mask her face. She doesn't want to see the people. This young man here, this making the fringe here, French, to mask is not a fashion. It's not ماهيش موضة. It is trying to cover the scars of the acne here. And look at this young lady, how it looks miserable and depressed here. So acne can cause a very, very important psychological burden. So it can cause embarrassment, can have to interfere with self-consciousness and self-esteem and body image, can make the patient, the young man or woman, very angry from him or herself, depression, anxiety. The patient cannot go parties, cannot go to meetings, cannot even marry. They broke their marriage or relation. They cannot work because of the acne. And sometimes they don't want to go to school or university unless they hide your faces with a lot of makeup. So always think about the psychological burden of acne on the patient. Now, the management of acne, how we should treat acne. There is general principle, there's a medical treatment, and there's a physical treatment. So general principle is general advice that you need to give to your patient. If you have a patient comes to you with an acne, you should always advise them, don't try to break the comedones or the papules. Don't scratch them because this will lead to infection and lead to scarring. Do not use strong soaps and strong chemicals and oily components, especially the cosmetics that are very full of oily, irritant, allergic compounds. Try to avoid them. Don't overexpose to the sun. Although the sun in the past being used or ultraviolet in the past used to treat acne, but don't overexpose to the sun, because when you burn your skin from the sun exposure trying to treat yourself or your acne, you will end up with skin cancer in the future. Stop smoking. Ask your patient to stop smoking. Avoid junk foods, which is debatable, but there are some studies saying that if you're eating a lot of junk foods, a lot of food containing carbohydrates and fatty foods, this will lead to increase of insulin, and the insulin will lead to increase to the comedones and acne. And try to use a very good friendly facial wash or cleanser on the face and wash the face regularly. So this is the general principles of acne. Then you have your medical treatment that you might be asked in your exam. If you have a short case patient with acne, what are the treatment of acne? And we classify them into topical, antimicrobial, which is just creams and ointment, topical retinoids, again creams and ointment, other forms of topical. Then we go to the systemic antibiotics or oral antibiotics. Then we go to these two together, oral contraceptives and hormonal therapy. And a very, very important part of the treatment is the oral isotretinoin, which used to be known as Roaccutane, which now called oral isotretinoin. The reason I have written this one in red is because this is a very, very important in the exam, in your exam. If I am your examiner, and if I find I have a case with acne, any examiner, myself, will directly or indirectly will lead you, will ask you about the isotretinoin or Roaccutane, and I'll cover it in a minute. So these are the treatment, medical treatment of acne. Start with topicals, then move to systemic antibiotics, then use contraceptive for ladies, some hormonal treatment, and then the isotretinoin. These are the topical antibiotics. You don't need to know every single one of them. You can say topical antibiotics like clindamycin or erythromycin gel. This is to treat the papules and pustules. And the side effects usually can cause irritation, can stain them, clothes, and can cause, stain is wrong here, sorry. So it can clothes and skin And the most important is develop resistance. So don't use topical antibiotics to treat acne very, very widely. Be careful when you use topical antibiotics. If there is no indication of topical antibiotics, do not use them. If there is no infection, mild infection that need topical antibiotic, don't use it. Or use it with the retinoids, or use it with the other topicals, because if you use topical antibiotic with the retinoids or the benzoyl peroxide, this usually will reduce the incidence of resistance. So first one, topical antibiotics, clindamycin, erythromycin, tetracycline. Then you have the retinoids. The word retinoids is coming from vitamin A. So it's vitamin A derivatives. It's coming from vitamin A. It doesn't mean that the normal vitamin A that you can go and buy it from the chemist or the pharmacy. It's a very specially modified vitamin A. And they work by removing the comedones. We call them keratolytic, good for comedones, and work as an anti-inflammatory, but it doesn't work as for infection. When you combine them, as I said, with the topical antibiotics, they are very good combination. And you need to know maybe one or two of the topical retinoids. Adapaline is the most commonly used one. And they can cause very severe dryness of the skin, scaling, erythema. That's why we always advise use them once daily, maybe at night. And use them at night because they can be either inactivated by ultraviolet, or they can make you very sensitive to the light, because they will absorb the light, the sunlight, and cause a reaction in your skin. Then a very widely used topical treatment for acne is being used for more than 100 years. Benzoyl peroxide is very widely used treatment. And this is have antimicrobial effect, have good keratolytic effect, can be used in its own, or can be used with others. You can use it with erythromycin or clindamycin, or you can use it with the topical retinoids. Then you have azelaic acid, which is a form of acid, and this is very important treatment for post-inflammatory hyperpigmentation. So if you have a patient with post-inflammatory hyperpigmentation, you can use azelaic acid. This usually will help to get rid of the brown pigmentation. And then about 2 or 3 years ago, we have the Dapsone gel, which is an anti-inflammatory. So these are the topical treatment of acne. You need to know maybe just know one of them: clindamycin or erythromycin, adapaline, benzoyl peroxide, and maybe one of these. And then you move to the second line, which will move from the topical treatment to the systemic treatment. And the topical treatment is systemic treatment, systemic antibiotics. Again, these are very important treatment for acne, particularly for inflammatory acne, but you have to be very careful about using them. You need to know when the right antibiotic, the right time for the right age group, and the right duration. Don't use antibiotic for years and years and years. And don't use, for example, tetracyclines in babies and children, because they will cause a lot of problems. Don't use tetracycline in pregnant ladies. So always be careful about when to use the antibiotic, what type of antibiotic you need to use it, for how long you need to use it, because of the side effects and the resistance. And these are, if you know, even these from 1 to 5, the names and the doses will be more than enough. Because if you have a short case exam of acne, they will ask you what the treatment, they will ask you what antibiotics. So if it's a lady or a man, a lady is not pregnant, or a man, you can say, I'll give tetracycline, which is now old-fashioned treatment. This is the doses, 500 milligrams 4 times daily, maximum 3 months time. And if the patient does not respond in 3 months, then you can review the patient and change. Then you have doxycycline, 100 milligrams twice daily for 3 months. Minocycline, the difference between minocycline and these two, this can be taken with food. Again, 100 milligrams up to 3 times daily. And these are the side effects. Most of them will cause a GIT upset, photosensitivity, drug rashes. Be careful when you use these medication with contraception, because these work, and particularly erythromycin will work what we call enzyme inducer. They will induce B450 on the liver, and this will be more active, and this will make your contraception, if the patient is using contraception to avoid pregnancy, this will make the contraceptive very low, and the lady could get pregnant because you have given her an antibiotic. So always warn your patient if you are giving these antibiotics and they are using a contraceptive in the same time. Erythromycin, so if you are in my exam and I'll ask you the patient is allergic or have side effects from the tetracycline, I wanted to say erythromycin, and this is the dose, GI upset and skin rashes like urticaria. And then you can mention trimethoprim, which is not very widely used. So these are the main antibiotics you need to know in the treatment of acne. But I repeat again, you have to be very careful. You need to choose the dose. You need to choose the type of antibiotics. You need to choose how long you need to use it and what are the age group, and make sure you are not causing any teratogenicity by giving to a pregnant lady. Then oral contraceptive, we call it OC, oral combined oral contraceptive pills. And these containing estrogen and progesterone. And these acting against the androgen, against the testosterone. And they usually reduce the production of androgen and sebum. They're very, very good treatment, even in their own. There are a lot of ladies just using the combined contraception for their acne and keeping it under very well control. So you can use it either alone, or you can use it with antibiotics or with isotretinoin, and you need to use it with isotretinoin. I'll say why in a minute. And oral contraceptive, very good for inflammatory acne, recurrent acne, comedonal acne, and resistant acne. Personally, I don't start them at oral contraceptive myself. I usually ask the GP, very rarely the gynecologist, to start this one, because you need, before you start any lady in a child bearing age group on contraceptive, you need to ask about history of migraine, severe headache, breast cancer, deep vein thrombosis, if the patient have got a vaginal smear or not. So always, although you can prescribe it, my advice to you, always refer to the general practitioner. GP means general practitioner. But bear in mind, oral contraceptive, combined oral contraceptive, alone or with the antibiotics, is a very good treatment. Now, hormonal treatment, there have been a lot of trying of hormones, but they were not very effective. The only treatment that has got an hormonal anti-androgen effect or hormonal effect is spironolactone. And if you did medicine in your 5th year, you know that spironolactone is a potassium-sparing diuretic, and usually used to treat high blood pressure, some forms of heart failure. And it has an anti-androgenic effect. It has affect the testosterone, and very good treatment in ladies. We don't usually use it in males, but we usually use it in females. And usually the dose 100 milligram daily. But again, if you're going to prescribe it, I prescribe it a lot sometimes, and you need to be very careful about the side effects of this treatment, and you need to keep an eye on your patient. So this is about the oral contraceptive and hormones, combined oral contraceptive, and the only one have got hormonal action is the spironolactone. I repeat again, the treatment is topical antibiotics, topical retinoids, and benzyl peroxide, dapsone, and azelaic acid. Then you have the systemic antibiotics, mainly the tetracycline and erythromycin. And then in ladies, you use combined oral contraceptive, and then usually use, sometimes in resistant cases, you can use a ladies spironolactone. Now, this is the most important part of the treatment. And if you go home today, or when I finish my lecture, you know what's this isotretinoin, I'd be more than happy. Because if I am your examiner in the short cases, and sometimes you see, you get a case of acne in the short cases in your exam. And when you come, the examiner will tell you, look at this patient, what do you think he or she have? So you look at the face, you will see comedones, you'll see papules, pustules, nodules. And then the examiner will ask you, either directly will tell you this patient have been treated with antibiotics, and if she is a lady, the patient is a lady, with oral contraceptive, but there's no improvement. Or he will tell me about the treatment of acne. So you might say tetracycline, oral topical antibiotics, topical retinoids, and he or she will say to you, this patient did not respond. So directly or indirectly will lead you to the isotretinoin. He or she wants to hear from you as isotretinoin. What's this? So isotretinoin is a vitamin A derivative. It's from vitamin A. We call it retinoid. It has a half-life of 10 to 12 hours. It metabolizes in the liver and stored in the fatty tissue. And that's why it has stayed a long time in our bodies. Then it works in almost all types of acne. It can treat inflammation, can treat cysts, can treat follicular hyperkeratosis. This is a very, very important treatment. Although it's only used in nodulocystic acne or resistant acne, usually the dose between 0.5 milligram to 1 milligram per kg. So you usually if you have a patient 80 milligram الويت بتاعه تقدر تبدا على 40 كيلوغرام 40 milligram daily increase up to 80, or you can start from day one, start on 60 or 80 milligram per day. And you can give it as a single dose. It's for usually capsules. You can give it as a single dose, or you can give it in 2 divided doses with food. Usually give it with food. The duration of treatment with isotretinoin between 4 to 6 months. Maybe longer, you can give it in smaller doses. So instead of giving, for example, 80 milligram, if the patient weighing 80, you can give it 20 milligram, but you need to use it for at least 1 year. You can use it multiple doses. You can use it, and after maybe 1 year, if the patient comes back, you can use it again. So you can use multiple doses, but make sure that the total cumulative dose, which means how much you're given in the first dose, should not be more than 150 milligram per kg. So if you give your patient, if you give a patient 100, if you give your patient Roaccutane for 4 months, you need to calculate how much you have given him and should not be more than 150 milligram. Side effects of isotretinoin. This is very important, and this is what we want to hear from you about isotretinoin. The most common side effects is dry skin. So can lead to eczema, can lead to infection of the skin, can lead to colitis, which is inflammation of the lips, particularly lower lips, can lead to muscle pain and aches, can lead to dry eye and scars, can lead to headache, can lead to paronychia, can make your cholesterol and triglyceride high, can make your liver enzymes is quite bad. So these are the most common side effects that we need to listen to hear from you in the exam. Hello? Hello? If you have a patient with hypertriglyceridemia or high cholesterol and high triglyceride, always be careful giving this treatment. And as a baseline, I always check the blood for lipid profile and liver function before I start the treatment. And then I do it 1 month later, and then I do it every 3 months. الو يا منير تسمع فيها؟ تعال. تعال منير. ما عادش نسمع فيه خير هذا. شوف اللي هو خربش خش واحد بده يخربش، ما عادش نسمع في منير، مش درت معاه الشير انا.
منو اللي خربش؟
لا دي اللي خلينا نكلم منير. تبرك ليبيا. منير منير
Say Munir again?
منير.
No, someone else اسمه Tobruk Libya. Like, I don't know why none of the...
خد اكتب خش الشاشة اللي هو يخربش، ما عرفتش من اللي يخربش برا الشات.
Oh, chat. No. What's that? Does anyone know who it is? من يخربش.
نعرفش.
عني.
علاش ميوت هو كان؟
لا عني أوس. What's that? There you go.
وين منير؟ فوق منير. منير منير.
Wait.
يتكلم هو لكن ما نسمعش فيه يعني.
Ja, schau das. Unser.
منير ما نسمعش فيك راه. الو. الو. منير.
What is this like? Who's doing that?
شنو هذا نشوفه كاتب. اوكي.
Wait, someone's
هو
scribbling.
اوكي. Can you hear me؟ تسمعوا فيا؟ نعم اوكي. Let's go back to the side effects of isotretinoin. So the most common types of side effects of Roaccutane, this is what, so when I ask you, or the examiner asks you, what are the side effects of Roaccutane, these are the most common side effects. So you will say, you need to say dry skin, which can lead to eczema, can lead to paronychia or infection of the hair, nails or skin around the nails, can lead infection of the lips, which is called cheilitis and ulceration, can lead to muscle pain and aches, can lead to dry eyes, and you have always be careful if you're prescribing acne to lorry drivers or pilots, because this will cause problems in the vision, can lead to headache, and then can make your cholesterol and triglyceride very high, can make the liver enzymes very high. These are the most common side effects, and these are usually dose dependent. عشان تعني يعني كل ما تعطي الدوز higher كل ما تكون هذه side effects. Practice, normal practice, and most of the consultant is to use normally check liver function, lipid profile before you start as a baseline. So I want, the examiner will say to you, the examiner want to hear these side effects from you, and he or she wants to hear from you that usually before I prescribe isotretinoin, I need to check liver function, lipid profile as a baseline, and 1 month later, and then every 3 months. And then the most important side effects. This is the one that you should always, not just for the sake of your exam, but for the safety of your patient. Mainly if you're going to prescribe isotretinoin in a lady in a childbearing age group, a lady that have started her periods after say 14 or 15 and up to 45 or 50, that she can get pregnant if she gets this while if she's sexually active. Which means if you give isotretinoin to any lady in a childbearing age group, you have to be very careful. And the lady should have what we call PPP, which is Pregnancy Prevention Program. Your patient should sign a consent form. This is what the examiner wants to hear from you. Any lady in a childbearing age group giving her Roaccutane should sign a consent form that she is going to use a contraception, preferably 2 forms of contraception, and she should not get pregnant. She should use the contraception up to 1 month before you start the Roaccutane or the isotretinoin while she is on the treatment, and up to 6 weeks after you stop the treatment, because the Roaccutane usually stored in the fatty tissue in our body and can be released even up to 6 weeks after you stop the treatment. The patient should sign this consent form. If the patient is less than 17 or 18 and she cannot sign, their parents or their guardian should sign the consent form. الولي الامر بتاعها اذا كان الطفله عمرها 20 ولا 19 ولا 18 ولا 16 ولا 15 وما تقدرش تعرفش تصاين وش متوقع، لازم تكتب في الملف ان الولي الامر وقع وعرفوا ان الايزوتريتينوين can lead to teratogenicity, can lead to abortion, can lead to malformation, can lead to brain defects, phase cardiovascular. You could see a lady in 30 and she have very severe acne, and you do not have any choices apart from giving her isotretinoin, which will save her face, will prevent the scars. But you should not give her the isotretinoin without the pregnancy prevention program. And you need to check the urine for pregnancy tests before you start the Roaccutane. Give the Roaccutane for 1 month, and every month the patient should come to have the second dose and check the urine for pregnancy. And then when you stop the treatment, wait another 6 weeks, and you should check the urine for pregnancy. So this is very important questions on the short cases and the multiple choice. Teratogenicity and the pregnancy prevention program. You need to use contraception. You need to check urine before you start, every month, and up 4 to 6 weeks after you stop the treatment. Isotretinoin is a very good treatment, but can cause a lot of complication and side effects. So this is what the examiner want to hear from you if they ask you about the side effects of the isotretinoin. Then very debatable side effects: depression, mood swing, suicidal ideation. This is debatable. I mean, I have been using Roaccutane for more than 25 years. I have had maybe less than 5 patients whom I have decided to stop the Roaccutane because of this problem. Generally, the patient will come to you very depressed, very annoyed, very low esteem and confidence because of their acne. And once you start the Roaccutane, their mood swing and depression will improve. However, if you think that The patient has got depression. You should not start the Roaccutane before taking the opinion of the psychiatrist and taking a very good history. So these are the most important side effects, common side effects that I've mentioned in the previous slides, which are these one: dry skin, eczema, paronychia, infection of the nail folds, dry eyes, muscle aches, headache, increased triglyceride and liver function, and cholesterol. An important side effects is this one here, the teratogenicity. You could mention about mood swing. So this is very important for the sake of your exam, and also for if you're going to work as a dermatologist. Don't prescribe isotretinoin without contraception in ladies. Then we have the physical treatment. So we have general principle, we've told about, we have the medical treatment. Then these can be used to treat acne. Laser, photodynamic therapy, steroid injections. So this can be used. You can inject steroids in a large 1 or 2 lumps in the skin that does not respond to the treatment, and this will work an anti-inflammatory and reduce the swelling. You can remove the comedones. You can use some surgery, but this is temporary, and this is limited, and this is very expensive if you're going to do it privately, and not available widely, where particularly in Libya. So the main treatment is general principle, and the topical treatment, systemic antibiotics, oral contraceptive, retinoids, and sometimes spironolactone. Now, what's new in the acne treatment? There is a new topical treatment called minocycline, topical form, and then can be used for up to 3 months and can be used in children up to 9 years old. There's an anti-androgen which works topically rather than giving spironolactone. You can use a topical anti-androgen called Roaccutane cream, and this will react with the dihydroxytestosterone, but you don't need to know these names. I mean, if somebody asks you, or for sake of yourself, there's a new treatment, minocycline, topical androgen, and typical retinoids, and triferiton. And this is usually does not, now comparing it with the adapaline, for example, this does not cause irritation and can be very good for moderate acne. There's a new antibiotics from the tetracycline family called sercycline. Now, this antibiotic can be very well tolerated, can be used in children up to 9 years old, can be used up to 3 months, and can be used in a low dose. It doesn't need 500 milligram, up to 150 milligram daily for 3 months. So these are the new treatment for acne: topical minocycline, typical anti-androgen, clastorine, topical retinoids, triferiton, and the systemic antibiotics, new variant of a new type of tetracycline called sercycline. Now, we nearly finished. So what I want you to go home with or understand from this lecture is this slide here. So I want you to know acne is a chronic inflammatory skin condition. Chronic means can take months and years to settle down, and is more inflammation. It's very inflammatory skin condition. I want you to know that you need to treat early and sometimes very aggressively to prevent any physical and psychological scarring. This is the second most important point you take home with. The third thing that you should always tell your patient, if he or she have got scars, that your treatment is not to treat the scar. You have to make it clear to your patient. Some patients will come to your skin clinic and will say, I would like to treat my acne, and he or she means the scar. The treatment we have told about, except this laser, the photodynamic therapy, the plastic surgery, that's treatment for the scar, which is out of our scope of this lecture. So always be clear to the patient. Tell him what the aim of your treatment, what you're going to give him. Tell him that your condition is chronic, so it will take months or weeks to settle down. Tell him it's or hair is inflammation. Tell him I would like to treat you to prevent any physical scars in your face and even psychological scars in your brain. And I'm not going to treat your scars unless you are doing laser or you're doing plastic surgery, which is another specialty. Now, these are in the second, so these are the most important. Then these boxes, he tell you about the causes of acne or pathogenesis of acne: abnormal follicular keratosis, increased sebum production, increased bacterial activity, and inflammation. And then these are the treatment: topical retinoids, benzoyl peroxide, hormonal therapy, antibiotics, benzoyl peroxide, dapsone, and then the isotretinoin. This is what you need to know briefly. This is before your exam, look through it and bear in mind what are the side effects of the isotretinoin. So this is a summary of the whole lecture that will be more than enough for your exam. Now, before I finish, a very important acknowledgement to the very important dermatological website where I've taken most of the pictures, dermnetnz.org. So this is if you would like to review or look at the pictures or look at some other dermatological websites, you look at this site here. And then I do hope that I have made this chap here who was angry at the beginning of lecture more happy, and we cured his face. And I do hope that you will know how to deal with acne as if you are a dermatologist or in case of your exams. Any questions?